Ladies and gentlemen, today I want to share you about the impact of management of adenomyosis in infertile patients. I'm Dr. Kilong Lee. I'm the chair of Board of Trustees. So we organize so many annual congress all over the world. 2017, the annual meeting in Yokohama, Japan, organized by Masaki Ando, and also a very successful one, and more than 3,000 participants in this conference. In 2018, APAGE annual meeting in Surabaya, Indonesia, organized by HIFU, is also very successful one, and more than 2,000 participants in this conference. And also we got the APAGE statement for the leg study. And 2019, APAGE annual meeting in Chongqing, China, and more than 3,000 participants in Chongqing again. And 2020, because of the COVID-19, so the annual meeting had postponed to 2024 in India. And this year, 2021, APAGE 21st annual meeting in Yokohama, Japan, is also very successful one, have more than 3,200 participants in this annual meeting. Even the COVID-19, there has so many attendants in this conference. Next year's 2022 annual meeting will be in Taipei. Welcome to see you in Taipei. So my talk about the management of the adenomyosis in infertile patients. First of all, we want to talk about the pathogenesis of adenomyosis. This figure shows the pathogenesis of adenomyosis and adenomyotic lesions due to endometrial myometry interface disruptions. Ultrasonic procedures cause disruption at the endometrial myometry interface, which lead to platelet aggregations and the induction of the HIF1 alpha, effectively causing tissue hypothesis. Uterine hypostasis may also induce EMI disruptions. As a result, genes involved in estrogen productions are upregulated, resulting in increased local productions of estrogens and subsequent inductions of the both estrogen receptor alpha and also the estrogen receptor betas, which in turn lead to induction of the oxytocin and oxytocin receptor signaling in an increased uterine peristalsis. In addition, tissue hypothesis activate TGF beta 1 and the VEGF, PDGF, COX-2, and the SDF1 signaling pathway, leading to increased angiogenesis, vascularizations, and recruit BMD stem cells to the winning side. The inductions of the COX-2 will also increase production of the PGH2 and the PGE2 and the TXA2, which also enhance the uterine peristalsis. Moreover, the TGF beta 1 signaling pathway induce TMD, leading the invasions of endometrial epithelial cell to the EMI and further down to the myometriums. So they can formations of adenomyotic lesions. Tissue injury also would activate HPA-Hs, and the HPA-Hs lead to the relief of the catecholamines and the PGE2, which correctly result in the impaired cell-mediated immunities and enhance the survival of displacement and disparate endometrial cell within the myometriums. Also, the event ultimately lead to the formations of the adenomyotic lesions in the myometriums. So, in clinic, the presence of endometrial glands, along with endometrial stroma and the variable degrees of smooth muscle hyperplasia within the myometriums, and the textures of the lesions maybe is solid, most is the cystic, and the textures of the lesions, most of the solid to mostly cystic. No consensus regarding the classifications of adenomyosis, classified internal or the external adenomyosis of adenomyomas based on degrees of the invasions. The diffusion disease scattered and the focal disease restricted, and the exomyometries, polypoid, endocervix, and retroperitoneums. So there is a very good classification in sonography. You can find according to the site and the size. We can define is a diffuse one or have a focal or adenomyomas, and the size we can find from the ultrasound. We can evaluations the type and the extensions of adenomyosis in the myometrium. It seems to be have an important in correlated to the severity of the symptoms and the infertility. So I think it's very important to classify and have a correct reporting system. Just like the first one, we should identify is the adenomyosis or another tumor. And secondly, we should identify the location anterior, posterior, left lateral, and right lateral or fundus areas. And also, we're looking for the differentiations is the focal or mixed or diffuse, or there is adenomyomas. And there is a cystic or not cystic. And also, they are the internal zone, or they have a middle myometrium zone, or they have outer myometriums. And the extent of the adenomyosis, it might just less than 50 of myometriums, moderate 25 to 50% of myometriums, and the severe is more than 50% of the myometriums. And the size of adenomyosis lesion, I think that is quite important for the outcome for the adenomyotomy and the comparison between the infertility and the pregnancy outcome. So I think the right classification for adenomyosis is very important. And so the treatment options is depend on the presence of special conditions, include pain, non-mutant breedings, and with or without the infertilities. And the options for treatment include medical treatment, surgical treatment, radiologic treatment, HIFU, and the combinations of the least choice. Here we want to talking about the adenomyosis with the infertility. So as the infertility, we're concerned about the when the patient needs treatment to improve the chance of pregnancy, and how to improve ART outcome post adenomyotomy or HIFU operations. So first, we want to know why the adenomyosis cause the infertility. First, because they get inflammatory change in the environment, and also sometimes they get adhesions that were influenced of the local environment, and also they get the endometriosis have a poor receptabilities and the low implantations, and locally they will increase the estrogen and decrease the progesterone level. So actually, they have a few data to support adenomyosis spatial outcome for the options. There are so many ways to interventions to the adenomyosis, include surgical way, include medical way, and how about compare with the placebo? We can find none of those. Maybe they have not good effect in treating the adenomyosis related infertilities and also gastrinol. But we're looking for the GNHA and looking for the surgery. We find the data show these things have a better outcome in using the GNHA and also the surgical treatment. Why? The pituitary down regulation will improve the fertility outcome because of they can reduce the inflammatory reactions, because they can improve the pelvic microenvironment. They improve the growth and development of the follicles and also improve endometrial receptability. And how about the surgical interventions? Surgical intervention is a very difficult. So we just defined when the patient have medical treatment failure, and so they get a severe dysmenorrhea and also have a hypomenorrhea and are difficult to control with medications. And also the patient, they have a recurrent miscarriages or infertilities. And they have a strong desire to preserve the fertility of the uterus. So the surgical intervention was suggested. Conservative surgical approach. The first report for conservative surgical treatment for adenomyosis in 1952 by laparotomies. So the laparotomy surgery include partial reductions, that is the wedge resection of the uterine wall, or modified reduction surgery, So that is the cytoreduction surgery. And they also have a transverse edge incisions of the uterine wall. And the complete adenomyotic excisions. That is the triple flap mesos or Satan mesos or systematic dissection methods. And recently, because of popular of the laparoscopic surgeries, so they have a laparoscopic adenomyotomy. In our group, we say that is a 4 flap meso. And according to the OSADAT have reviewed, totally they have 2,365 cases of adenomyotomy, including laparotomy and laparoscopic surgeries. And 397, they got the pregnancies post-operated. And 337 reside in live births. So they got 84.89% have a successful live birth deliveries. And 23, it means 5.79% have uterine ruptures. And also the results of the OSADA methods, the 10 years study in the 104 patients. And they can find they have used the triple flap technique for cytoreductive adenomyosis and also the uterine reconstruction with the special aim of the maintained fertility. And 61% of women desiring fertility became pregnancy, and 54 of them have been turned pregnant and delivery, and none of them have uterine ruptures. So that is the triple flap method used by the OSADA. So they cut out the adenomyoma lesions, and according to the lesion have been completely resected until the 1 centimeter of the endometrial cavity. They have a bivalve first, and the adenomyosis lesion have been H-shape removed. Then make a sutures on the endometrial cavity. Then flap was to cover the opposite side bilateral. Then the restore, the flap was covered again there. So that's OSADA method. I get a very good result of the surgery. How about the laparoscopic adenomyotomy? In our group, we have a 2 to 4 flap method. Okay, here we show you our method in the adenomyotomy. Whichever the surgical rule we use, the challenges of the adenomyotomy include possible misdiagnosis and also the defining the extent of the resection. Here, the first endometrioma, we have a drain of the endometriomas, and we suspend the ovary first. Then we use the ultracision to open, to resect the adenomyosis lesions using the transverse line on the uterus until the endometrial cavity. So we can find here, it's just about the 0.5 centimeters subsillus layer have a relative normal tissues here. So we use a technical lens to withdraw the endometrial lesions and use harmonic scalpel to excite the lesions. And that is quite difficult to approximations. And during association, the complication is the most difficult in adenomyotomy. And here we can find all the tissue is quite solid and condensed because of fibrotic change on the myometrium here. Okay, we use the section irrigation on the left hand and harmonic scalpel on the right hand, and resect it as much as possible until the endometrial cavity. The principle of surgery mimic those of the myomectomy, so we can left the normal tissues as possible. And this cytoreduction surgery they still have some visual tumor just left there. But here is the relative normal tissues already here. So first, we cross the first layer of the myometriums, just like the cesarean sections, across the day space first, just like in the myomectomy. And the second layer, we just have a approximation further, and the molecular stagings and the repair is still the paramount important in these operations. So the flap of the uterus again attached to the opposite side, and the fourth layer sutures will approximation again. Okay, so here we can find the uterus have become almost a normal size again. So another video showing how to reduce the bleeding during the surgery. Okay, during adenomyotomy risk during the laparoscopy includes you can have a UNHA preoperatively, or you can use the uterine artery blockages during the surgery, or you can use the vasopressin injection in the uterus. And also you can use oxytocin infusion during the surgery. And the most important is the defected side should be closures medically, and make a very quick stitchings for closures by the experienced surgeon is very important. It's a 42 years old woman. They suffer from meningitis, and they got the adenomyosis there. So the procedures, we use the two flap methods. Because of the using the endoscopy, so we use the transverse incisions. So here is the adenomyosis, and we use a harmonic scalpel to remove it all. Okay, so here we can find all the adenomyosis lesion have been resected away, and using the three flap method, we can find the intrauterine folly just there. So first, we just crossed the endometrial cavity. Then the posterior flap have been closure first, and secondly, the right side myometriums just cover again. Lastly, the upper portions of the myometrium cover again. So that is a three flap the surgery. So we can find the right side myometrium have been approximated on the left side. And the upper myometrium is covered again. So here we can find that is a three flap method here. So the factor causing uterine rupture include the remove methods and the decrease of the extirpations, and the extent, the size of tumors, and how much reconstructing surgery necessary, and the wound, did you get infections, and how long after the surgery they get the conceived, and how about the skill of the surgeons. And also they have some disadvantages of adenomyosis. Because of the disadvantages of adenomyotomy include they have changed the environment of the pelvic cavity, and also they get a higher rate of uterine rupture during delivery or in labor, and sometimes they need a longer waiting time, and it's very difficult to dig deep adenomyoma. And in my personal suggestion, at least 50 laparoscopic myomectomy experience you need before you're doing a laparoscopic adenomyotomy, especially for the diffuse type adenomyotomy. So another one is HIFU. Actually, HIFU is a revolutionary, complete, non-invasive, non-surgical treatment. They conduct it under precisely imaging guideline, which could select abrade the lesions, little affecting the normal, smooth uterine muscle structures. Energy is capable producing thermal coagulations, negotiations at the precise portions. After treatment, the lesion can be absorbed by the tissue nearby. There is no adverse effect on the function of the ovary and the endometrius, as the ionization radiations is not used. So HIFU is here, so we can find when we're doing the surgery, they can have the patient just sit up in prone positions and just have a HIFU machine just beneath of the abdomen. So that is our case that have adenomyosis here. Before HIFU, we doing the MRI exam of the surgery. They get very clear, have a liquidations of the tumors, and the myometrium, collagen fiber, and the elastic nearby the abrade target can also be conserved without change the biochemical properties, and hence the uterine dilatation during pregnancy and the contractility during the delivery are retained. So there is no extra risk for the patient from becoming pregnant soon after the HIFU treatment. So that is another way to treating the adenomyosis. They have a subfertility. That is my patient. They have presented by Professor Song previously, and 35 years old. They have after HIFU, they get spontaneous pregnancy. Here is the photo they show here. Okay, so how about the outcome for compared with the HIFU and the laparoscopic adenomyotomy in the patient with adenomyosis? And the data from the Central South University from China, they collected data from the 2012 to 2017. Totally, they got about the 93 patients and the 50 with HIFU and the 43 with the laparoscopic adenomyotomy. And they can find after the treatment, the frequency rate a little bit higher in the HIFU group. As the natural cycle or assistant cycle, they have a little bit higher in the natural cycle in the HIFU group. And also they have no obvious complications in the most of the group. So make a conclusions, HIFU show a safe and effective profile as therapeutic management option for the patient with adenomyosis. And HIFU treatment achieve a better postoperative reproductive outcome in compared with the laparoscopic adenomyotomy, because of laparoscopic adenomyotomy, they will be very technique dependent, and HIFU treatment should be encouraged in improvement in the clinical practice. So who will be the benefit from the uterine spreading surgery for adenomyosis associated with the subfertility? From the paper from the Japan, Dr. Chyi talking about the patient below 39 years old and beyond 40 years old. That in the two group, we can find they get a higher pregnancy rate in the patient. They have a lower than the 39 years old. They have a 41.3% of the pregnancy rate. When compared with the older, more than 40 years old, they have just 3.7% of the pregnancy of the surgery. And that effect associated with the clinical pregnancy will be the history of the IVF treatment. They have an old rate 6.22. And the positive wall involvement, that is odor rate ratio is 0.18. And the overall age is 0.77 respectively. And so we can find the age as the determinant in the fertility outcome. Surgery could be a benefit treatment for the woman who is experienced IVF treatment failure, especially the age below 39 years old. If the patient have beyond the 40 years old, we can find the benefit on the treatment. And also the subendometrial myometrium tumor should be treated very careful, that because of the not only the intrauterine synechias, but also later on they maybe have some risk for the placenta accreta. So they have a very good flowchart from the China Medical Society, the Society of the OB/GYN, and the patient, if they got adenomyosis, and if they want to have a ART, I think the age, if lower than the 39 years old with the normal ovulations, so in this situation, UNIHA treatment maybe is quite good. And after treatment, if the uterine size is still largest, then we use the 3 to 6 months again. If the size have decreased, then maybe we can use the frozen the embryo transfer. If not, we can have a conservative treatment. And if the uterine size less than 12 week extended age, then you can have an embryo transfer. If they have a recurrent miscarriages, then we can have a conservative treatment, adenomyotomy or HIFU surgery. And waiting for 3 to 6 months later, we can have a frozen embryo transfer again. And if the patient, if the aged woman larger than 39 years old, or they have decreased ovarian functions, we can have the myostimulations and have embryo preservations. And if they have still have a large uterus, then we can get another 3 to 6 months UNIHA, and if not become normal size, decrease the size, then we can have conservative treatment. If they have get a good result, then we can give them a long protocol and have a frozen embryo transfer. I think that is a very good the flow chart for the patient with adenomyosis. So that is also called the segmental ART that just talked about with the Dr. Sun have mentioned about pre-treat IVF and the pre-treat and the frozen embryo transfer. I think that is a good way for the patient with the adenomyosis. So make a conclusions, how we management the adenomyosis in infertile patients. And the previous making the decision to have the operated adenomyotomy, one should consider if the conservative medical treatment may elevate the patient's symptoms without objecting her in the risk of surgery. If you want surgery, experienced surgeon is necessary. Adenomyotomy should not be the be-all and end-all in the managed adenomyosis. That is means they have the post-operative, they have give the use of adjuvant therapy operatively and to improve patient outcome. They have a more effective symptom control and the low symptom related rate. And the intervention is indicated if the medical treatment failure and repeat miscarriage of infertility, and the strong desire to preserve the uterus of fertility. And the HI indication before ART include hydrocephalus, fused endometriomas, failed ART, and the condition may exacerbate the IVF outcome. So in this situation, you can have the surgery. And the segmental ART for the adenomyosis patient should be in college is the best options. And HIFU show a safe and effective profile as a therapeutic management option for the infertile patient with adenomyosis. Because of the non-invasive in the patient, they have a repeat failure. Maybe the HIFU can be the first choice, then the operative, the adenomyotomy. Thank you for your attention, and see you in 2022 in Taipei, the APAGE 2022 annual meeting in Taipei. Thank you. See you.